So, hello everybody. This is me, Dr. Mameghani from Switzerland, from the Kantonsspital in Baden. I start 2 minutes late because I have an emergency in the OR. And I just want to say hello to everybody. Today it's a talk about the management of L5 fractures. It's not me alone who is presenting. We have Dr. María Cavagnaro from the University of Buffalo. She's doing her fellowship there. She's a board-certified neurosurgeon, and she is trained in Argentina. And thank you, Maria, that you're here. Dr. Cavagnaro will give a presentation and showing her research, which she has done at Arizona University together with Dr. Bach and Dr. Bransford. They published last year, and it's a great paper and so much to learn. And today I wanted to start with this introduction because I implemented some interactive features I did before, and it's very easy. You just have to take your iPhone now and go to the QR code and log into this presentation. You can type in www.menti.com, and then you can use this 8-letter code. And then you see right the vote module, and it's completely anonymous. Nobody will be able to track you, and you can answer some questions I'm asking here. Actually, I'm in a hospital now, and I'm using my my laptop, and I have only limited features. But I hope that somebody from the faculty and the panelists will join and help with some questions. First, as always, my disclosures has nothing to do with this feature. It's trauma, it's fractures, it's emergency surgery. It's nothing to disclose. So when I start the first question, I ask you, please, can you pin on your mobile phone or whatever device you're using, can you just show where do you think is the fracture? Very easy, but maybe it's fun because I've hidden a second fracture here. And if you now look, sorry, on the screen, you can see maybe several dots or your dot. Many have chosen the right site, and the talk is about L5 fractures. Very easy. Can you show me what is your opinion about this fracture? How would you treat this fracture? Would you do this conservatively because it's too dangerous? Would you put the patient in bed rest? This is possible. This was a treatment before we were able to decompress the spine, like in the 20s, no, in the 19th century. In the 20th century, we were able to perform laminectomy, and then in the second half, we were able, in the end of the second half, to perform stabilizations. And I think with 1990, we were able to do these 360 fusions, 360 degrees fusions. And I just wanted to ask you, how would you treat this fracture? And now we have eight votes, and it's pretty tied up. 4 say definitely posteriorly, and 4 say anterior posteriorly. Unfortunately, you can't change your vote. So once having submitted your vote, you can't change it. Just wait a little bit so you can join this system again. For those who joined in a little bit later, if you go to menti.com and use this code, it's always written on top on my presentation, on my talk, you can log in and participate, and this is the interactive feature. So L5. Now the majority, it's not a big majority, say anterior and posterior. So another question, if you have this surgery planned, who will do it? What do you think? Who can manage this surgery? Is this a procedure that a chief resident can perform? Or is this an attending after 1 to 3 years? Or do you think you need a trauma or tumor or deformity fellowship? One of these fellowships where you learn to do the anterior spine, the deformity correction, resections, where you lose your fear from the vessels and major surgeries? Or do you think even a fellowship is not enough? It needs more experience than you think, like an experienced surgeon, 5 years of practice and lots of emergencies. So it's pretty nice. You see, this is a really interesting increasing numbers say it needs an experienced surgeon. And I posted on Twitter that these L5 fractures are not really the low-hanging fruits of spine surgery. And it's so true, like the herniated disc, where the patient is crying, is in 10 VAS, and is crying for pain, and you do a simple surgery like a discectomy, and the patient loves you for the rest of his life because you are his hero. Sometimes a herniated disc, we know all these complications are possible, but these are some low-hanging fruits, and you can have a fan for the rest of your life. So majority says, oh, you have to be skilled surgeon experience. So I show you first a case. This is not my case. It was published 2019, not in a peer-reviewed journal, but on this internet, this webpage, Spine Universe, and it was published before the pandemic from Dr. Vaj, and he was showing a case of a young male patient after a motor vehicle accident with severe motor weakness, like 0 from 5, L5, and the trauma was examined, and I can only show the cases from him. This is the axial view, the case from Dr. Vaj. And if you now have a look to this fracture and the motor weakness, you can see the solution is pretty big. There was posterior first instrumentation and laminectomy, and then second, the corpectomy was performed L5. This is the CAT scan post-op, and you can see the end plate, the lower ab plate sitting on as one, this oblique as one, like a skiing piste. This is the comparison we use in Switzerland the most, is pretty high. You see the complete posterior wall is removed, so this is not a corpectomy we do sometimes for stabilization. This is a corpectomy for decompression as well. And he had to struggle with some CSF tears. Everything is written in this source I've shown you 3 slides before. It's very interesting, short, but you can learn a lot from this case. So what do you think? What was the most challenging feature of this surgery? Was this restoring of the lordosis? Was this dealing with the vessels, with the iliac veins, the bifurcation, just crossing in the middle of the upper region where the cage is, or was this the dealing with the CSF, the dural tear down in the depth? What do you think? What is the most challenging feature of these surgeries, posterior and then second anterior? I don't know whether Dr. Vaj is already joining, whether he can jump in and tell us what is the most challenging, so we can proceed and ask him later if he's able to join. So most are thinking and fearing the vessels, yeah, And of course, the vessels, this is the anatomy. Somebody has to mobilize them. You can't take out L5 in this amount like he did, just by slipping and sneaking around the vessels. You see the diameter of this cage it's a huge cage. And dealing with CSF and dural tears, I know that all these orthopedic surgeons, I'm an orthopedic surgeon, we don't love CSF a lot. And when we see these injured dura, the cecal sac and spaghettis coming out, this is not really that part of the spine surgery that convinced us to go into this field. So the vessels, the dura, and restoring lordosis, yes, but not as much. So again, this is the anatomy. You see the problems, and the intervertebral disc L5 is 1 is visible, but where is L4? Where is L4-5? It's usually right under the bifurcation of the great vessels, and it's challenging. Another anatomy here, you can see L5 is just below the epsilon, the V on the top, or lambda, as you want to call it. And now I would love to hand over to Dr. Cavagnaro from Buffalo University now. She did some amazing research and publication together with Dr. Bartsch and Dr. Bransford, and together with a fantastic colleague, Dr. Orenday, who did all these illustrations. Maria, Dr. Cavagnaro, can you just take over and I skip from side to side?
Yes, thank you, Dr. Mameghani, for inviting me. This is a really nice job we did last year with Dr. Bransford and Dr. Bartsch and all the team. And it's funny because I always say I really like a quote from Picasso that says inspiration exists, but it has to find you working. And that's the reason, like, the research ideas is always came from some patients, no? So we have a patient, and so Dr. Bartsch nicely resolved, and we say, okay, let's look what is in the literature about. So we met Dr. Bransford, and they work in a very big trauma center in University of Washington. And we asked him and said, really, I don't have so many cases. So let's take a look. So we planned it. We found the cases. So that is something that we have to know. Even at big trauma centers, fractures or in L5 are very rare. And because they are very important part of the sacroiliac junction with the rest of the spine, we have to distinguish from different of the thoracolumbar fractures or other fractures in the entire spine. The most important thing is that not only play a role in connecting the rest of the spine with the sacroiliac junction, with the rest of the pelvis, sorry, is also very important for the lordosis. So that is the reason where we, maybe deformity surgeons, we see a lot of flat back when there is not a good correction of the lumbar lordosis. So something that you have to think about that. So these fractures are usually very rare, occur after a high energy axial compression, most falls or motor vehicle accidents. So that is very common in trauma centers, and are more type A, we consider like type A or 4 or 5 that are the burst fractures. That's the most common time. So what we did is first did a systematic review. Yes.
Sorry, it was just my fault. Sorry.
Okay. You can continue with the other slides. We decided to do first a systematic review, and also like look in the case series that we have. We used like Prisma protocol was used, and we found 169 patients reported in the literature in 29 studies. So we consider only traumatic injuries, bar fractures in adults. We rule out all osteoporotic infections, oncology fractures. So analyzing these patients, there were like 3 strategies. One was conservative management, the other was surgical, and in between surgical was doing corpectomy or without corpectomy with posterior fusion. And the extension of the fusion also like have a variation. So we have this patient, we have 79 females and 19 male, that is more related to the trauma that are most common in men, and young people, the main age is 32 years old, and with a mean follow-up that was 28 months was considerable. So something that you have to take a look at these fractures is different. If you receive a fracture at the conus at T12, 1 or 2, these patients will be probably have a neurological deficit, because at L5 the canal is bigger and we have only roots. We don't have the conus. These roots have the behavior more like a peripheral nerve, so have a better restoration if we treat these patients quick, and also there is more space to have the fracture or the occupation of the canal without a neurological deficit. So you see the percentage, 60% of the patients were neurologically intact, with our canal stenosis range from 20 to 90%. So very important, we found that the stenosis range of the canal didn't match with the neurological deficits of the patient. So patients with 90% of the canal stenosis, they didn't have any deficit, and something to consider. And these patients, someone can be treated conservatively. So that's something to consider. Also, other thing that we have to consider is that all this stratification that we use, a scale that we use, may not be really reliable for these kind of fractures, especially in L4, L5. So the Tillich grade classification is have not so good reliability in these patients. So these patients were treated 46 conservative, 41 with posterior lateral fusion, and 15 with corpectomy. With the patient that had radicular deficit were 34, and they were treated mostly with posterior lateral fusion, only 9 with corpectomy, and 6 conservative. And after the patient with Guadalupe syndrome, they were all treated surgically, with most of the case with posterior lateral fusion and laminectomy. Some of them were treated with corpectomy. So this is very important because we know that some patients can be treated conservative, and they were treated with best rest, followed for 3 or 4 months of external lordosis and early ambulation. Only some cases, because they were very like before the 2000 year, they were treated with prolonged best rest. We know that this patient doesn't need prolonged best rest, and normally they need with what we call like the most early physical therapy, with external lordosis. That it will improve the outcome of the patient. So the patient without neurological deficits all remain neurologically intact after treatment. So this is really important because we treat 60 patients. Most of the patients that we treat, we have 60 patients without neurological deficits, and 6 that were treated without it, and they maintain intact. The patients that were treated have neurological deficit, but were treated not conservatively, they didn't do well. So 33% of these patients, they have complications. So what is this? That means that patients without neurological deficit can be treated conservatively, but in patients with neurological deficit, we will try not to do that. Speaking about alignments, not all the patients were reported their outcomes of the alignments, but we didn't find a significant loss of lordosis in these patients. Only 4 will show improvements. Okay, and regarding the patients with surgical intervention, most they were treated with L5S1 instrumentation and laminectomy. So this patient, we have 86 patients treated without corpectomy and 31 patients treated with corpectomy. The corpectomy was, the approach was anteriorly in most of the cases, except in 4 cases was posterior. Complications or intraoperatorial is what the Dr. Mameghani was speaking about. When we are doing an anterior approach, we have the vessels and there is a risk of vascular injury. Normally this we do with access surgeon, that the access surgeon can resolve this without complication, and this was what happened with this patient. Regarding postoperative complication, 11 patients with have complication in only posterior fusion and 1 with anterior corpectomy. So complication was only 1 hematoma that have to be evacuated, and most of the patients have cellular arthrosis. Important is all the patients without neurological deficit remain intact. Regarding alignment, we know that L5S1, L4, L5 are the most important part of the lordosis in the lumbar spine. So we have to think about this, especially if we are deformity surgeons and we are thinking about these people is a young people, is mostly young. So these people, we have some problems in the future. So we found that the patient with only posterior fusion have a loss of lordosis, most of them, that was not significant. However, the patient with anterior corpectomy, they have an improvement of 5 to 8 degrees of the lordosis. So, regarding the posterior corpectomy, we didn't find, we only have 4 cases, so we didn't take results about how improve the alignment or not. Mostly they have to improve because we know that we are replacing in the anterior body that is fractured, so they have to improve, but we didn't have it, the results. Next one. So this is our the cases or the complications, and this is an important. I really like this paper that Dr. Cavagnaro published, and I know I think he published a video. I don't know, operative neurosurgery on Nexus. It's a really nice because he explained the technical aspect of when we do the L5 vertebrectomy for a posterior approach. That is very similar when we do VCR for L4, sometimes for deformity correction, but in L5 sometimes it's more complicated for the inclination of the S1, and you have to find the correct cage. And I think he explained very well and have a very good result in this patient too. So this is the systematic review that we did, but when we met with Dr. Branford and Dr. Tavolaro, that they are from University of Washington, we can get 8 patients that were treated in that hospital. Mostly all the patients were young people, of course, after a trauma, and they were treated different and with different options. And the follow-ups barriers, we have only 1 that was lost, but most of them was between 6 and 24 months. And so I will show now some examples, and maybe we can talk about Dr. Mameghani or someone that you want, talk about what will be the surgical alternatives. So this is an 18 male that was doing longboarding and have an accident. So we already decided to do with this, we can say the vars fractural L5 with compromise of the posterior wall, and it seems like the lamina, the pedicles they are conserved. However, there is a more than 40% of the canal occupation. The patient have a L5 radicular deficit. So in this point, we can plan to do a reconstruction of the vertebral body, or do only a surgical to resolve the deficit. If you can show the result of the second case. So I think that this was a really nice case. They did a corpectomy and they achieved a very good lordosis at that level and a good fusion. So if you can see the lordosis that they achieve, maybe we will be not able to achieve with only a posterior fusion. Any question for that?
So thank you very much, Dr. This is very nice because you see these implants are quite old. Yeah, so this is an open surgery. This is, I think, it's a USS system, and as it says, these are monoaxial screws. You have to bend the rod. You need some skills. Today we are a little bit intended to do the easy way. Just to do it minimal invasive, perk screws is so easy compared to an open reduction of this fracture. Maybe this case is some years older than the news one. I think it's a really good result. And of course, the patient is 18 years old and he is losing L4-5 motion segment. He is losing L5 as one motion segment. But I think for decades, it was clear you can't preserve motion. It is a loss. This accident has taken away these two motion segments. There's no alternative. Maybe we will have a paradigm change in the future when we are able to restore lordosis, if we are able to restore a vertebral body without fusing the patient. But I think what we here see is really, really great, but you need a lot of surgical skills to perform this.
Yes, I think Dr. Bertuk asked if they did laminectomy. Yes, sorry, I didn't show the CT scan of this patient, but the patient have a laminectomy. And all that you can see in the posterior part is all the fusion that for the graft that they have.
So your second case?
Yeah, the second case is also male, is 26 years old. And I showed this one too together because it's like, they are the two different indications. This one is L5 for the surgical procedures and would go also good results. This was a L4-5 laminectomy with a posterior fusion, was a short posterior fusion. When we think about doing only short posterior fusion, it's trying to limit the fusion and maintain some mobility to the patient, of course. This have a 72-month follow-up, and the reason probably why they fuse so nicely is because he's 26 years old, but he really have a really good fusion. The patient have semi-neurological exam before surgery and no pain. So this is the controversy we have now. So we are doing something less with this patient, achieving a very good lordosis without complications. But this is something that can happen, but it's not always like, sometimes we can have like pseudoarthrosis or not the same fusion, or a flat back secondary to only posterior fusion. So it's something that we have to think about, like, of course, about the patient. So our studies show that with anterior corpectomy, for sure, we improve the lordosis, but we have the same neurological results and not much difference in complication with both results, with both strategies. So we can show the third case. This is a 37 male. We also, in this case, we decide to do posterior fusion and L5 corpectomy. So you can see here the L5 burst fracture. In this case, it's not so much collapse. It's more collapse in the superior end plate with not much displacement, and the patient was intact. So it's in this case, we did a corpectomy and posterior fusion, but if you see the review, there's some cases that this patient will be treated conservative. So something that we cannot know if the patient will do good without treatment, but it's something to consider, especially if you are thinking about someone old, no? Someone like with patient with osteoporosis, someone patient that with a lot of comorbidities, we can consider this treated if the patient is intact conservatively, according with our systematic review. The last case is 49 years old. The patient fall. In this case, they decide to do a longer fusion. It's important to clarify that these cases are always decided for different surgeons. In the University of Washington, most of the cases are for Dr. Bramford. But if you compare it with our systematic review, most of the patients do L5S1 fusion, but they say that they have same results when it's L5 to ilium or to the pelvis. So this patient have a trauma, so we didn't have a initial motor exam, and we see we have a 30% of the occupation of the canal with the varus fracture, especially and also the lamina. So we can consider that this patient have also anterior posterior column is affected both columns. This patient was treated really first with posterior fusion, and he has 9 months after have cellular arthrosis. So they decide to do AlphaCorpectomy, and 2 years follow-up. We see the nice fusion and nice lordosis that the patient achieved. So in conclusion, for this case, neurological injuries are not correlated with the degree of canal stenosis at L5, and that is because the canal is bigger, because the roots there, they have the behavior more like a peripheral nerves that the spinal cord, so they have better recovery, and the patients do better, do really well after surgery. So we can say that after L5 fracture, neurological injuries have a promising prognosis. If we are thinking, especially as in these patients, like a young patient, we don't want them to come back in the future, we can consider about the restoration of the sagittal imbalance, and the best we can achieve with the anterior corpectomy. It would be nice to see more posterior corpectomies, to see how the results about the lordosis what we achieve, but we have to clarify that the posterior corpectomy is not easier than the anterior corpectomy. You have to deal with the nerves. You have a small corridor. It's not easy, so you have also many risks. And in cases with patients with good alignment, non-operative treatment can be considered. So it's not crazy someone say we will not treat these patients. Thank you.
Oh, thank you very much, Maria. This was a really nice overview. Yeah, I think when you have a case series from 8 patients, this seems to be a small number, but it isn't. It's really a big number, and we have to be honest. I think nobody loves these L5 fractures so much. There are so many easy fractures. This is you don't have to misunderstand me, but with easy fractures, I mean, is a simple plan like 2 above, 2 below, and anterior corpectomy. This is a procedure you can train your fellows, your attendings pretty nice, and then these L5 fractures are there, and they are a lot more challenging. I have a question. Yeah. Maria?
I think that now that we know more about it, it's like, I feel like we have some response about it, no? So it's something that maybe if someone that have no experience, you have in a 4 a.m. L5 bar fracture, I think we have some, there is not, of course, it's not a trial, it's not a meta-analysis, but we have some response. We have know which patient can do better, which patient we can wait, and we like what we can do. I feel like if you are in a trauma center and you don't have experience like a deformity surgeon, I feel like doing an L5 posterior laminectomy, S1 and fixation is not a bad surgery. I feel like you are helping the patient because you know that the patient will improve. So I feel like especially if you are working, you are not a specialized trauma surgeon, and you always can come back and do a standing scoliosis and see the patient that didn't have a good lordosis and do the anterior part in the other part. So I think at least it's good for someone that is at 4 a.m. in the hospital and doesn't know what to do with the patient because that's never saw this one before.
Yeah. I think this is an important point here. If you go anterior in the acute setting, and this is what I wanted to ask everybody, what about the timing of surgery? Posterior decompression, when there is cauda equina, we know time matters. Do it from posterior as soon as you can. And we are trained for this. We are trained for a posterior approach. But what about anterior? Usually anterior second is the surgery we do when the hematoma is down, when the bleeding risk is down, whether coagulation disorders in the polytrauma are better or back to normal. There's a lot about research about the golden hours of trauma, the golden hours, and then we have to wait because the patient is in full inflammation. And the timing of surgery, I don't do anterior surgery in the acute setting. Interestingly, the discussion of this case from Dr. Bach and Spine Universe, there were two responses. The one said yes, anterior first, posterior first, anterior second, if necessary. And the other comment was, you could have done this anterior first. And this is something where I really, it shivers a little bit, because I think anterior first in the acute setting to decompress the spinal canal from anterior, this is really something you have to be skilled, you have to be really experienced, and I would not recommend this, not in this audience. So,
sorry,
yeah.
Dr. Mameghani. I will respond to Dr. Du that say how reliable and values the TLIX in evaluation of L5 these fractures. There is one nice work with also Dr. Bramford about it's not about L5 fractures, it's about lower fractures. It's about below L4, so L4, L5. They consider like a group of patients, and they say that the TLIX is not so reliable because you cannot consider here the rupture of the ligaments like one pattern of instability. So with that saying, you cannot consider, it's not there. They say in that study that they don't consider this scale, this classification for this patient. So they will not consider this reliable.
Yeah, that's a good point. If you don't have the time and the team to do research, literary research, you can Google. And if you Google L5 burst fractures, you see some injuries, you see some solutions, and they're pretty the same. You can always find anterior posterior, you can find posterior only. You can see nasty fractures like these. Please don't think that any surgeon is saying, oh yeah, I'm going straight forward with these fractures. These are really luxation, C-type fractures, nasty things. I think it's hard to publish a textbook about these fractures because they are rare. They're really rare. But these posterior fragments we see quite often in L5, for example. And you can find so many pictures and to put research and literature all together, it is not an easy fracture. And I'm glad that we've heard this excellent talk from you because complication rate is high. Not every complication is a disaster, that's true. But when you are the surgeon and you have a vascular injury, your pulse, your heart rate is going up. This is the you've read the reports about ischemic legs, losing a leg due to anterior surgery, and you don't want to be the next surgeon who's sued because you did it. And this is really challenging. And L5 fractures are completely different to L3 or L1 or T12 fractures. And whenever reasonable, it's better to avoid surgery. I want to emphasize is don't try to be the hero. It's wiser to avoid surgery if the patient is neurologic intact. Look, wait, follow up, and then you can do the deformity surgery in an elective scenario. So my case, oh no, surgery is recommended. 50 years old, he jumped from the height and he had L5 palsy, unfortunately an incomplete caudal equina syndrome. He had sphincter tonus. So this is the CAT scan, pretty similar to the ones we have seen before. I just wanted to run through some images. Of course, it's clear why the right side is worse than the left side. And you see an additional sacral fracture here on the right side as well. The major hit was from the right side. You know, from the publication from Roy Camille about jumper fractures, usually it's the sacral fracture, but now the jumpers have got foot and ankle injuries as well. You see both calcanei are fractured, and the patient, it was a polytrauma. So going to this, I just wanted to ask you, what's your opinion, your recommendation if you look at this CAT scan I showed you? What is the best? He has a neurologic deficit, and it's not a minor, it's a major deficit, hemi-cauda equina syndrome. I don't know whether you are able to vote. What do you think? Bed rest, strongly disagree, or do you strongly agree bed rest is good, or posterior decompression stabilization? After we heard this nice talk from Dr. Cavagnaro, the question is anterior first, posterior second, or posterior first, anterior second. Okay, I made this comment that I don't recommend anterior first, but I think it's clear. The majority would do posterior decompression stabilization first, and one half goes anterior as well, and the other half leaves it with a stabilization decompression only. So I proceed. This is the solution I did. It was posterior first. You see the decompression on the third image is a laminectomy, a wide laminectomy. I didn't do L4 as one. I did L3-4 as one, and I went to the ileum. So I had some problems with the anatomy. I couldn't do S2 AI screws. These are really ilium screws going a little bit through the SI joint. Sometimes in a trauma setting it is. It was a dural tear. I've seen CSF making sutures, pushing the fragment a little bit anteriorly. It is not so anterior as I wanted, but it's better than before. And then if you see the rod bending, I bended the rod a lot to restore lordosis a lot, maximum lordosis. The patient had to stay in bed because the foot and ankle surgeons did the calcaneus fractures conservatively. The patient was in the wheelchair. He could sit. Yeah, so he's here. You see now here the sitting X-ray and the lordosis. I didn't do any posterior fusion because my plan was going posteriorly, decompress, stabilize, and then go second anteriorly in an elective setting. But the patient was fine. He didn't have any back pain after the surgery. And he said he didn't want to do the anterior surgery now. He wanted to wait. And he asked me, can I wait? And to be honest, I cannot lie. I cannot say, no, you have to go this corpectomy. So I said, yes, we can wait. Let's have a look when you get up after 8 weeks. So 8 weeks of bed rest and the calcaneal fractures, he was able to get up, to stand up. And this was the first X-ray. And he was nearly pain-free. And because he was pain-free, and we did so much discussions, now the plan was anterior corpectomy or 3-level ALIF. So you see here 3 discs. They are pretty nicely visible. You can do disc surgery or you can do corpectomy. So let's ask the audience, what is your recommendation? Would you do corpectomy L5 and later maybe an implant removal posteriorly? Would you do corpectomy L5 and XLIF L3-4, or would you do ALIF L4-5 and L5 as 1, not L3, 4. What do you do this 3-level ALIF I mentioned, or do you think, well, when the patient is pain-free and he is able to get up and walk, let's wait and see. So many voted for wait and see, and the 3-level ALIF, I'm glad somebody said 3-level ALIF, because this would be really nice disc surgery. It's a lot less bleeding than you do a corpectomy. What I love from Dr. Orenday's illustrations is that he put some blood into the illustrations. Now, when you see some textbooks, then there's only a gray or a brown bone, and there's no blood to be seen. But if you do corpectomy, you know from cervical spine, corpectomy is a lot more blood than discectomy. So the message is clear, wait and see was a majority. So I show you what happened. The patient was fine. We said, okay, let's make some observation, and you see something's happen. And it's not happening inside of the construct, it's happening above. And the patient always had an elevated CRP, not severe, but significant. And suddenly he had a bacteremia, the blood labs, and it was an enterococcus. And we didn't know why is there this change. This is not instrumented, but an radiation level. You see the contrast 4 months post-op, there's enhancement. And unfortunately, I don't know why he had this infection, vertebral osteomyelitis, in this level. Second, maybe hematogenous, we don't know. But it really, I couldn't believe, but they made a PET scan as well, and we have to face the fact there is an infection. So what should I do? 4 months after surgery with vertebral osteomyelitis in a radiation level, everybody recommended hardware removal or renewal and debridement, as there's no biofilm active antibiotic for these enterococcus. Some bugs we have biofilm active antibiotics, but in this not. And so I did a change. I had to reduce. These are bigger screws and new screws. Everything was stable. And here, antibiotics, 3 months, the patient healed, but this segment went down. What a pity. So it's so frustrating restoring lordosis, and then these osteomyelitis comes, and the patient was really coping with the pain like it's, yeah, a little bit pain, but it's not hard. I want to work again. And you know, patients who jumped from the height and not by accident, these are special situations. So we didn't push him. We said, okay, we will now do a lifelong observation, and we follow up. And the patient is not doing well. He's doing great. He works 100%. He is doing sports, and he is somehow fine. He's back to life. And you see here, the CAT scan, the infection, everything is healed. This is nearly 2 years later. Still is he in my routine, in my control. I see him regularly. L5 remodeling. You can do everything now. You can do deformity surgery. You can do, or you wait. And this is what I wanted to say here. It is not healed. There's no fusion. There's no loosening of the screws. The patient is fine. Lessons I learned, less is more. And it's like Sisyphus. You're doing something really hard work, and then the stone goes down. And my nice restoring of the lordosis, everything was heavy work for really an outcome with a kyphotic lumbar spine. So when you please take the chance and give me your opinion, your thoughts. Is wait and see really a good philosophy, or do we harm the patient? Because he is in a bad sagittal balance. He has got a kyphotic lumbar spine. Would you say wait and see it's not good or doesn't harm? would you think that this guy needs surgery in the future? Yes or no? Or would you say, let's see, maybe, maybe not? Would you think that maybe I should have been more aggressive? That it would have been better to go straight to the OR and say, okay, 2 days later I go anteriorly. I have to fix the problem. The patient will have big benefits when I am more aggressive. Would you have done exactly the same? Or what is your thought about anterior surgery anyway? Is fear of going anteriorly, is this justified, or is this just a myth? Just call your general surgeon colleague, just call your vascular surgeon colleague and fix the problem. Where there's a will, there is a way. You need a team approach, and then you will manage everything. So I'm glad that the majority says wait and see doesn't harm. The majority says the patient needs surgery in the future. Thank you all for saying no. Being more aggressive is not the better option. And some say they wouldn't have done exactly the same. Some would have done exactly the same. It's nice to see these bars. I'm very glad about the third one. Being aggressive would have been better. That the majority says no. As we heard from the talk, that there's no wrong and no right. Going anteriorly is not a mistake. Going not anteriorly is not correct. So my next case is something completely different. 85-year-old female, minor forehead at home. She has been in my clinics. I knew her due to spinal stenosis. This was 3 years before, and I recommended conservative treatment, and she was fine for 3 years until this minor fall happened. And you see the axial T2, recess stenosis, bilateral. And now what happened? Okay, L5 fracture. Severe in pain, back pain, a little bit radiating pain. And what do we find? We find a vertebral compression fracture, L5, no involvement of posterior elements. If you look at the axial T2 now, it's pretty the same. There are minor changes, but overall, there is a stenosis. There's also stenosis 3-4, but the patient has predominant back pain due to this fracture. What to do now? This is the standing X-ray. I don't have whole body, whole spine standing, but she was in pain, and you see a slight slip, you see posterior fragment, you see the depression, loss of height of L5. So this having said, I just want to ask you, L5 fracture and the pre-existing stenosis in an 85-year-old patient, what do you do? Conservative, the easiest cement augmentation possible, the vertebroplasty, or a fancy cement augmentation with a balloon or a stand or whatever. You know all these brands, all these fancy names, but it's just a cement augmentation with the aim to restore more lordosis. Or would you say, okay, you are an unlucky situation, you have the stenosis pre-existed, let's combine our approach and do open decompression and do some cement? Or would you say, okay, this is a perfect case for decompression and fusion because she has a slip, she has a bad kyphotic situation now, let's do open decompression and fusion. These 5 options are possible. The patient, 85 years old, she lived at home alone, and she wanted to go back home as soon as possible, as quick as possible. No relevant disorders. So many say decompression is something good, plus cement or fusion. So let's see what I have done. This is the pre-op image, and then I went for minimal invasive, put in 2 Yamshidi needles, 2 K-wires, did these restoration of the vertebral body, put in the cement and reduced the fracture a bit. This is pre-op, post-op in the detailed view. If you see here, the lumbar spine overall pretty the same. If you measure, there's a lot more lordosis. This is minimal invasive, and I just wanted to show these solutions now, because we all know these are available in the osteoporotic spine. Now I want to ask you something completely different. Would you do cement augmentation even in younger patients with L5 fractures? In the review of the literature, in the case series of the paper we have heard, there was no solution with cement. There was no kypho, no stentoplasty, there was no vertebroplasty, but this is a tool, minimal invasive. You don't need to struggle with the vessels. You have minor blood loss. Can this be a solution? Well, let's say we do some cement augmentation, put the patient for 4 weeks in bed rest, let the other injury components heal. Maybe we can save some motor segments here in an L5 fracture. Everybody knows L4-5, L5-1. They are range of motion. They are a major player in the mobility of the lumbar spine. Could this be an option now or in the future? Ja, nein in German means yes, no, very easy. And I also gave the option to be not convinced yet. And it's nice, you know, when I would talk to my teacher, he would say, no, never. Yeah? If I now ask my younger attendings, have you heard about these options? Yes. An interventional radiologist would of course say yes. In our audience, we are predominant surgeons. Now I want to just, yeah.
Doctor, I really think that there are like different pathology. Like when it's like a osteoporotic fracture is a different pathology than a traumatic fracture. And when the people is over 80, we want to do the less and try to help them to recover their previous activities. When we are young people, we want to try to be a little more aggressive, not even maybe in one time, but we try to do like the best for the alignment and also for the neurological improvements. I feel like it's a different case. I will not do a cementation in a young person in my short practice, but in an old person, I would do more conservative treatment for sure. We have a patient like 1 month ago with a very bad L5 brass fracture. We really just treat conservatively and she's doing well.
Yeah, and you're absolutely right. And where do we come from? We don't come from cement augmentation. We're coming from open surgery. We come from screws and vertebral body replacement. This is the past. This is what we all were trained, and your teacher were trained, and you are trained. And this is what our thinking is. But maybe just this question, maybe these minimal invasive options are a solution for the future. And let's say I have a dream that there's a patient with an L5 burst fracture who is treated successfully without losing 2 very important motion segments. Maybe we will manage. So I don't know. I would never recommend this surgery as this is proven and this is quite the same effective. But I just wanted to ask the audience whether it's possible or not in the imagination. We don't have the experience yet. So having said that, I just want to go to the 4th case because this is something completely different. Here we have a situation with an L5 fracture after surgery. You see here L3 5 fusion. This was the first post-op CAT scan. I'm a little bit unlucky with the cage size and the subsidence even now in the first CAT scan. And what happened 6 months later? 6 months later, there's chronic fracture of L5, not a burst fracture, something completely different, like in the paper we've got presented. And now we have this situation and fracture, neurologic deficit, L5 palsy. And I just want to ask you here now, this is not L5 fractures as we expected when we opened up this conference, but I wanted to ask you, with this chronic L5 fractures combined non-fusion L4-5, what is your treatment of choice in this situation? Would you do is conservative? Would you go for ALIF L5 as one? Would you say I go posterior with a TLIF? Or would you say I do a PSO L5 because the patient is badly imbalanced in the sagittal alignment? Or would you say yes, but it's not enough to go L3 ilium, she needs T10 pelvis? So as we are running out of time, I just let's have a look here. Yes, sorry. Some say PSOL5, some say revision TLIV. I bet Dr. Selby would sneak under an ALIF, L5 is one, hyperlordotic. It is difficult. These situations are difficult. This is not a young patient where the bone is good, where you can do anything. This is an older lady where the bone has proven to be bad, osteoporotic, fractures, not union. Nice results. Thank you for the poll and for interacting. And now I show you what I did. This is the image, the whole spine. And I did this PSO. You see in the resection of the complete pedicle. So I will show that L5 bilateral is completely free. I used some cement to augment the spine. In L3 it didn't work. The cement went into the disc immediately. L4 was fixed with cement. I went to the ilium. And this is coronal view. And this is the post-op whole spine standing. It is better than before, but you have to know, when the patient has got an L5 palsy, she will not recover fast. The rehab takes so long. She was a little bit unhappy because she said, I'm 82 years old. Why is everything getting better so slow? And this is what I wanted to mention. When a patient has got L5 palsy, just don't say surgery will solve your problems quickly. You have to tell them the recovery will take its time, 1 year, 2 years, but she can walk alone without a cane, and she is happy with this ability. But she's unhappy, and you run into depression if life is not as it was before. So now we are 5 minutes over the time. I want to thank you all for joining tonight when we're talking about L5 fractures, and I'm so happy that I was not presenting alone. I just want to skip to the last slide very, very fast because I have some pages here. This is, sorry. I just wanted to ask you where you are right now. Thank you very much for joining us tonight. And next week, the topic will be announced on social media, as always, on Twitter. And I am very lucky, Maria, that you have supported me. Thank you very much, Dr. Cavagnaro from New York, University of Buffalo. I appreciated your talk so much.
Thank you for the invitation. I appreciate that. Well, I really like your system. I will try to use.
Yeah, and this is easy setup. I'm orthopedic surgeon. I can understand this. You are really faster than me in this setup, and it's really nice that the audience can be interactive and make their decisions.
Yeah, great, Sarsion. Congratulations, it was a really good talk. Thank you.
So, thank you, Dr. Cavagnaro. Bye.